afternoon, everybody. I think all of you now on the screen, you know me. So it's my pleasure to welcoming you to this FMER Advanced Research webinar with one of our colleagues at McGill, Professor Dr. Jacques Balayla, as a guest speaker. But I will stop here. You know that it's customary in our group that if one of our FMER affiliated graduate students are available for doing so, the student will introduce the guest speaker and also facilitate the event. So today is Joshua Ramos, who will be acting as facilitator. So I pass the word to Joshua immediately. Thank you. Joshua, go ahead.
Yeah, so hello and welcome everyone. Thanks for joining this FMER Advanced Research webinar. Today we have Dr. Jacques Balayla presenting his research on diagnostic confidence in family medicine. A little bit about Dr. Balayla. He is a board-certified obstetrician-gynecologist at McGill, a clinician investigator at the Lady Davis Institute of Jewish General Hospital. He holds a Master's of Public Health from the University of Montreal and completed postgrad training in genetics at Harvard University. His research focuses on developing innovative models that enhance our understanding of information processing and diagnostic decision-making in clinical medicine. His work earned him international recognition from numerous accolades, including being named a Killigan Scholar, Quebec's Emerging Medical Professional of the Year, and receiving the McGill Alumni Global Young Alumni Award for having extraordinary contributions to McGill. Dr. Balayla is also the author of Theorems on the Prevalence Threshold and the Geometry of Screening Curves, which is an Amazon bestseller that introduces novel approaches to diagnostic reasoning and clinical decision-making. If you have any questions about his presentation and/or research, feel free to leave them in the chat, and we'll have a Q&A session right after his presentation ends. With that, I'll pass it over to Dr. Balayla to begin your presentation.
All right, can you guys hear me well? Okay, wonderful. Well, thank you so very much for the opportunity and the privilege to be here today. I'm delighted to be able to share with you a bit of my research and to hopefully foster a discussion and perhaps even get you to think a little bit about your own sort of way that you look at essentially arriving at a diagnosis. So the title of my talk today is Enhancing Diagnostic Confidence in Family Medicine, the Clinical Applications of the Prevalence Threshold as an Educational Tool. As a disclaimer, I am an advisor for Bayer in their Women's Health Division. However, my relationship with Bayer would not impact the contents of the presentation today. Second disclaimer, this presentation today is based on the contents of the book that Ms. Ramos just spoke about, which is known as the Theorems on the Prevalence Threshold and the Geometry of Screening Curves. I had the privilege and the pleasure to publish this book regarding the theory that I'm about to speak to you today last year with Springer Nature. The structure of this presentation is a little bit different than perhaps what you might be used to. So I kindly ask that you keep in mind the following. I will review and summarize two different ideas, which you are fairly familiar with. And then we will essentially try to see how these two ideas merge together with some novel ideas, if you will, that I'll bring forth and how we can integrate this into clinical examples. And so obviously, while the theory presented here today really relies heavily on mathematics, I ask that you please don't get bogged down on any equations or any technical terms. It's really, truly not the points of today's presentation. And if I've done my job right at the end, hopefully you'll be able to understand the contents of it without getting bogged down into the details. So let's talk a little bit about, in part one, what clinical judgment and decision-making are really all about. Clinical judgment is one of these very broad umbrella terms that we have no definition, essentially, or standardized definition for. Oftentimes, you will hear and you will see in the literature ideas being spoken of like clinical reasoning, clinical decision-making, clinical evaluation, diagnostic inference, all of sort of these sub areas of clinical judgment. And like I said, the point is not necessarily to find a common definition for clinical judgment, but to see rather how we can elucidate it through all of these other ideas. And for that, we really need to speak in very, very basic terms. As many of you know, the clinician obviously has many roles, but all roles really stem from the most fundamental one, which is to determine whether an individual is healthy or is sick. Everything else will stem from that. And so to accomplish this role, amongst other things, we gather information. And this is sort of the investigative role that clinicians have. And therefore, an understanding of the clinical process of information gathering is critical. What is really information in clinical medicine? Well, information really refers to data that has been organized and is interpreted in a way that conveys meaning or knowledge that can then guide clinical judgment and decision-making. These include signs, symptoms, test results, risk factors, medical histories, outcomes, as well as research results and innovations, among several others. And as we will see, the advantage of the Bayesian process or the Bayesian approach really is that it renders these different sources of information readily comparable. And so what is really clinical judgment if we try to kind of hone in on the definition? Well, clinical judgment refers to the cognitive processes that underpin clinical decision-making, allowing us to develop degrees of confidence in our clinical assessment. It really plays important roles throughout the diagnostic process, notably in formulating a hypothesis based on observations, in gathering data, interpreting that data, arriving at a diagnosis, and identifying appropriate courses of action in the best interest of the patient. The issue relies really on this idea that it is traditionally taught as a subjective process, which is ill-defined in the sense that it lacks a standardized definition, because it doesn't really conform to a single standard definition or process. And so why is it necessary, therefore? Well, you can sort of play this through a proof by elimination, if you will. Because if there was always diagnostic certainty, you wouldn't need judgment. If there was never any diseases in the first place, you wouldn't need judgment either. If there were infinite resources, you wouldn't need judgment. If there was infinite time, no judgment would be necessary either. And so really, clinical judgment allows the clinician to navigate the diagnostic journey in a setting of diagnostic uncertainty with limited time and limited resources. This process, however, is not perfect and is subject to biases and limitations. And so these biases you're all familiar with. This idea of, for example, having availability errors or biases, which is when you choose a hypothesis that first comes to mind because it came to mind first. There's ideas such as representation errors, where you focus on the presence or the absence of classic manifestations of a disease, but fail to account for others. Premature closure refers to the idea that sometimes we jump to conclusions prior to gathering all necessary data. Anchoring errors occur when you cling onto an initial impression, even as conflicting or contradictory data accumulates. So you do collect all of the data, but you essentially then neglect it or fail to account for it. Confirmation bias is this idea of cherry picking. Attribution errors, which is when you make decisions based on stereotypes, and affective errors, which is when you let personal feelings, either positive or negative, about a patient affect decisions. Now, we're all guilty of some of these, and we try always to mitigate them, but this is really what brings the human factor in clinical judgment, and it is, in fact, what is at the root of the differences in diagnostic approaches between individuals. And so how can we improve clinical judgment, seeing as it's difficult to define, it's riddled with biases and limitations? Well, we need a comprehensive approach, that's for sure. Things like education and continuous learning, which we're engaging in at the moment, and this is part of what we do as clinicians, of course. Identifying and mitigating these cognitive biases, which is easier said than done. Thoughtfully integrating technology, we're seeing this more and more, of course, and the promotion of collaborative environments. In the book, however, what we do is we attempt to provide a bit of a paradigm shift with regards to clinical judgment and decision-making from a qualitative, subjective process to a more quantitative, objective process as it pertains to diagnostics. And so to conclude part one, while clinical judgment really remains essential in medical practice, it is not precisely defined, and it is subject to cognitive, emotional, systemic, and environmental biases and limitations. And understanding these limitations is crucial for improving diagnostic accuracy, reducing errors, and more importantly, optimizing patient outcomes, which then brings us back to that primary foundational role of the clinician, which is to determine whether somebody is healthy or is ill. This brings us then to part two, which is unrelated, but we will see how they relate to one another on part three. And these are essentially basic principles of epidemiology and Bayesian theory that you're all actually very likely familiar with anyway. So we begin with the topic of screening. Screening is the tool that allows us to accomplish that foundational role. We first investigate or gather information through a process of screening. And this information is collected, whether it be through tests, observations, or history taking. That technically counts as screening. We have this idea that screening is only tests that you send a patient to do. But in fact, anytime that we ask a patient a question, or we perform a physical exam to look for some finding in the absence of symptoms, what we are doing is we're actually talking about screening. And screening is therefore defined as the presumptive identification of unrecognized disease in asymptomatic individuals by means of tests, examinations, or procedures. And this as stated, aligns with the clinician's foundational role, which is what allows us to establish that dichotomy between health and illness. As we know, different screening tools have different discriminating abilities to establish the presence or the absence of disease. And for that, we look at the very famous screening parameters, things like sensitivity, which is what is also known as the true positive rate. You would ask, for example, amongst patients that have a disease, let's say they're diabetic, how many would test positive if you were to test them for diabetes? Specificity is the same question in the negative sense. You ask amongst patients without the disease, how many would end up having a negative test? In other words, in women, for example, who do not have breast cancer, how many would have a normal mammogram? Now, notice here that sensitivity and specificity treat the subject, the patient, as the subject of the focus of attention. On the other hand, the predictive values, the positive and negative predictive values, actually don't focus so much on the patient as the source of information, but rather as the test. In other words, it inverts the question from the sensitivity and specificity, and it asks actually amongst positive tests, how many patients will have the disease. In other words, if you have an abnormal pap test, let's say in somebody, how many patients will end up having actually cervical cancer? The negative predictive value, say you test somebody for, you screen somebody for depression, let's say, and how many of them will actually be depression-free? And that's what we call the negative predictive value, because it focuses on the test, whereas the sensitivity and specificity focus on the patient. And so once again, you can just switch essentially parts of the sentence to obtain the sensitivity, specificity part, or the predictive value part. And I really want to focus primarily on the predictive value part because it actually respects the chronology of the diagnostic process, right? You're obtaining a test in order to diagnose somebody. If you knew beforehand whether a patient was affected or not, outside of the context of research, knowing that a test is sensitive or specific, assuming that you know the endpoint anyway already, is not actually very useful. And that's why I want to focus a bit more on the predictive value. Now, this might be a little bit new to some, but it's not all that complicated. And in fact, it's actually quite a powerful tool, this idea of Bayesianism or Bayesian theory. Bayesianism is a philosophical approach that interprets probability as a degree of belief rather than just a long wrong frequency. It uses Bayes' theorem to update these beliefs when new evidence appears. And this is a framework that really underpins a variety of fields by systematically handling uncertainty. So, for example, the example that is very common is if you want to know whether tomorrow is going to rain, you look at different parameters and you put the probability of rain based on those parameters. That's how meteorologists do this. That's how, for example, airports calculate the times that an airplane is bound to arrive, etc. It has really to do with the conditional accounting of certain facts in the context of other facts that you know exist. And Bayes' theorem is the mathematical theory that provides that relationship between the screening parameters, which essentially give you the probability of disease after you account for a sensitivity, specificity, and the baseline risk of the condition in question, which is essentially nothing more than the positive predictive value. In other words, the reliability of your assessment is given by Bayesian theory. And so how would you interpret the positive predictive value using Bayes' theorem? Well, let's say that you see somebody coming into the ER with chest pain, and you know based on the data that you've collected in your emergency room that out of 100 patients that come with chest pain, 70 of them would have an MI, let's say. Well, then you can say that there's a 70% chance that you're having an MI. You can tell that to the patient. That's what a frequentist or somebody who's a non-Bayesian would say. Bayesians, on the other hand, would tell you not so much that there's a 70% chance, but rather you interpret that probability, like I said, as a degree of confidence in your assessment. So you say, I am 70% confident that you're having an MI. You're essentially answering the same question, but you're actually looking at this from a different angle. And we'll see why that's useful in a moment. And in fact, if you want to really put Bayes' theorem into a question, you can always ask the following question. Given how suspicious I was before and the nature of the new evidence, that is to say the test results, how persuaded should I be now that the patient in question has a disease? And in fact, you can plot your degree of suspicion, or what we call your pre-test probability before you've tested them, and plot that as a function of your, well, rather, you can plot the posterior probability or the post-test probability as a function of your pre-test probability after you account for the test results. And that will give you essentially a sense of persuasion, a degree of confidence in your assessment. This is Bayes' theorem, again, one of those equations that you don't really need to remember, but the idea is that from Bayes' theorem, you can actually come up with the equation for the positive predictive value, which is, again, giving you that confidence, the degree of confidence in your assessment. And essentially, the positive predictive value, again, not to remember the parameters in the equation, is really proportional to the sensitivity, to the specificity, as well as to the pretest probability of disease, or what in Bayesian circles is known as the priors, or essentially your degree of suspicion prior to testing that somebody, for example, walking into your office with abdominal pain might actually have, Crohn's disease or pancreatitis or whatever other idea that you might fit in your differential. Well, you attribute different degrees of certainty, of confidence, if you will, on your assessment. And so how do we interpret values on this sort of x-axis, what I told you? In the Bayesian sense, which a probability still lies between 0 and 1, but because now you're representing the degree of confidence, what essentially that means is that the more signs and symptoms that a patient exhibits that are pointing you towards one direction, the closer that pretest probability is to 1. So for example, if somebody has polydipsia and you're thinking perhaps this is somebody who's diabetic, well, you assign a certain probability to them, but in fact, the probability will shift once you find out or you screen for other symptoms, which again, this is just in history. You can say, well, yes, I also have polyuria. And then that's shifting your probability so that your degree of suspicion is growing prior to you having actually technically diagnostically tested them. And you can continue doing this for multiple symptoms until you get to a point where you've accounted for all of the information that you could possibly have, and then you've convinced yourself that the test is warranted and therefore that you should go ahead and test. But there is really nothing specific about the clinical context to Bayesian theory, because in fact, you can do the same thing about pretty much anything else. Think of an object that is red, and then you realize that it's round, and then you realize that it has a pit, and then you taste it and it's sweet, and then it has seeds. Essentially what you are doing is that you are collecting further and further information, and you are refining your confidence that in fact, what you're dealing with here is, let's say, an apple in this example. So it's the same equation, it's the same train of thought that applies. How good of a discriminating ability does your brain have to determine that something is an apple versus not? How likely it is that you're dealing with an apple in the first place, and apples are fairly common, right, in the world. And then you essentially obtain a degree of confidence or a predictive value, if you will, when you input all that information into the equation. Now, there's a lot of variables, and the equation looked a little bit complicated, but one of the ways in which we can actually simplify Bayes' theorem is, in fact, not to deal with sensitivity and specificity individually, but rather to calculate what we call likelihood ratios. And the positive likelihood ratio in particular is defined as the probability that a positive test would be expected in a patient with the disease, divided by the probability that a positive test would be expected in a patient without the disease. In other words, if somebody, for example, has breast cancer, what is the probability that you would have an abnormal mammogram in breast cancer over the probability that you would have an abnormal mammo in somebody without breast cancer? And obviously, the better the test is, the more discriminating nature of the test, the higher the discriminating nature of the test is, the likelihood ratio will go up. That's a number that goes from 1 to infinity, assuming that we're talking about the positive likelihood ratio, which allows you to rule in disease. And it is simply defined as the sensitivity over the complement of the specificity. In other words, sensitivity over 1 minus specificity. Again, the values itself are not really all that important, but it's a fairly simple equation. And so now you can then translate the positive predictive value equation, as opposed to being a function of, let's say, A and B, which are sensitivity and specificity here, as a function rather of kappa, or your positive likelihood ratio. Again, no need to remember the equation. And so to conclude part 2, sensitivity, specificity, and predictive values really relate that pretest probability, that degree of suspicion before you've even tested, via that equation. And a way to consider sensitivity and specificity together is to use the likelihood ratio. Bayes' theorem then will provide that toolbox to update probabilities with additional tests, following this sort of Bayesian philosophy and framework, which essentially views probabilities as representing degrees of belief or confidence, which then allow you to update those beliefs using that theorem, that equation that I showed you firsthand. Okay, so those are the two first parts. Those are the things that you're fairly familiar with, I would expect. And what I'm going to do now is I'm going to talk to you a little bit about the novel part, or how we can actually extend this to its logical conclusion. This is the bit of the more interesting part, and this is the part that people tend to be have a little bit of a more difficult time in grasping all of the concepts. I'm really going to try to make it as simple as possible so that we can have a nice discussion after the fact. But let's talk a little bit about epistemology, and unsophisticated epistemology at that. Epistemology refers to the study of knowledge. In particular, it means how do we come to know things? What does it mean to know something? Obviously, I am not a philosopher. I lack the expertise to speak on epistemology, but I think a simple illustration can actually help illuminate part of the answers to these questions. So if I were, physically present there and not doing this through Zoom, obviously I would ask you who is this person whose, I guess, pinky finger you're seeing there? Well, some of you might know, some of you might guess. I would gather that most people wouldn't know because simply there is not enough information. In other words, the test that I'm providing you here, or the data that I'm providing you, lacks sufficient discriminating ability, if you will, to be able to determine essentially what who the person in question is or what the image is all about. On the other hand, if I went to then and give you a little bit more data, and now all of a sudden you see a hand and half a face, I actually don't have to show you the whole picture yet to know that this is Trump. And in fact, what that's really telling us is that I've given you partial information and you were nevertheless able to obtain the valid full conclusion. I'm going to give you another example of this. And if I ask anybody what brand is this, I am sure most of you will know that this is in fact the Coca-Cola logo. I have simply given you a sliver of the Coca-Cola logo, and you were nonetheless able to determine that that's what it was in the first place. So why is that? Well, I'm going to go through a bit of a thought experiment with you right now. A thought experiment is an experiment essentially that you conduct in your mind and for which you need no data, no tools, no instruments, just essentially the rules of logic and essentially more lived experience and common sense. So what is the marital status thought experiment? This is an example that we give in the book. But let's say that you see a person that's walking down the street. And then I ask you, you know nothing about this person. But let's say that I ask you, well, what are the chances that that person is married? And you can gather a guess based on the time of day that it is, what city we're in, how the patient or the person is looking, what age gap would you give them? Are they wearing clothes that suggest, that they might be professionals? Are they out in 2 o'clock in the morning? There are many things that can point you in the direction of somebody being married. But as it stands, you really have no idea other than that. Let's then say that in a second scenario, now they're holding the hand of another person. And I ask you the same question. Well, what are now the chances that that person is married? Certainly, you still don't know the actual probability, but you can definitely say that it's certainly higher than the first scenario. That doesn't guarantee that they're married. For all you know, there might be actors in a movie and there's a camera crew down the street filming them. But the point is that the idea that they're holding hands increases the likelihood that they are married, though it does not guarantee it. Therefore, we go on and we collect further information. And now let's say that there is a child in between them. And I ask you the same question. What are the chances that the person is married? Then let's say that, they're each wearing a wedding band that matches. And there's a date inside of it. Let's say that then you check their ID somehow and you notice that they share an address. And I ask you the same question every time that I've updated the scenario. And I say, well, what are the chances that the patient or the person in question, is married? Well, you could, in theory, right, continue to obtain more and more information about the individual in question until infinity. This is both impractical and rather obviously not the way that the world works. And so the question becomes, how much information do you need in order to be persuaded that the person in question is married? How much information did you need to know that that picture that I showed you was Trump, or that was the Coca-Cola logo, or that you're driving in a car and it's safe to drive? You're not assessing the position of every car. You don't know exactly where each molecule of each individual who's ahead of you is lying. But you gather essentially partial information and you navigate the world based on conclusions that you draw from partial data. This is what we do at every second of every day. And so we know, therefore, that in order to recognize and identify the presence of an object and a pattern or even abstract constructs like illness requires some input information. We all likewise have experienced situations whereby the amount of information necessary to reach a persuasive conclusion is often a fraction of all of the information that's available. We see this in politics all the time, right? They call out candidates are winning even before all of the votes have been cast, because essentially statistically there's no chance that they can be beat. We've all left sports games early because we know that the score was such a differential that there was no point in spending all that time in traffic just to leave the arena or the stadium. And so essentially the analogy in clinical medicine would be reaching a predictive value that is personally satisfactory should be enough for you to say, okay, I have seen enough, quote unquote, or I have collected the amount of information that to me seems persuasive enough to move on into the next step of the diagnostic process. And so therefore, this is the problem of analyzing all of the information that is available and once again, optimizing the inference process to reach a conclusion. We saw from that screening equation that the proportionality between the pretest probability or the prevalence in the general case and the positive predictive value is given sort of Bayes' theorem. But the question remains is what is the nature of said proportionality? So from the examples in the earlier slides, we concluded that beyond a certain point, right, adding new information didn't really significantly improve or alter your assessment. Indeed, not all information increases the probability of your conclusion being valid in the same way. And so we conjecture, if you will, that the proportionality is not linear. And how can we prove this? Well, a simple way to do it is visually. We can plot that sort of Bayesian screening equation to obtain a screening curve, and we can analyze its geometry. And in this case, the x-axis, the horizontal axis, is your pretest probability, your degree of suspicion before you've tested. And on the y-axis is the positive predictive value, or in more sort of Bayesian terms, is the confidence in your assessment axis. And essentially, when you plot that equation, you get a graph like this. And so note that the relationship between the predictive value and the prevalence or the pretest probability is not linear. That is to say, an increase in prevalence does not give you the same increase in the y-axis. The exact shape of this curve is really dependent on the sensitivity and the specificity, and therefore the likelihood ratio of the test in question. And obviously, I could give you more examples after we have some time, but this is just one equation. There's a critical point here, if you notice. Think of it like a cliff of sorts, if you will, below which the predictive value will drop most precipitously, and beyond which it actually doesn't change very much, right? You see the vertical part below it, and you see the horizontal part beyond it. This is what we call the threshold of prevalence, or the prevalence threshold. It represents the point on that curve beyond which the positive predictive value stabilizes, and below which it drops most precipitously. So one of the theorems in the book will actually show that beyond the threshold, the slope, if you will, of that horizontal part is actually 1 over the likelihood ratio, such that you will start getting diminishing returns once you've collected enough data to go past that threshold. And so once again, in green, when you increase your priors, your prevalence, or your pretest probability, and you collect more data, your conclusion actually is very unlikely to change because you're in that sort of more horizontal part. And in red, essentially, you're decreasing your reliability because you haven't gathered enough information. And we'll see how we can apply this into a clinical algorithm in a minute. Perfect. And so how do we calculate that prevalence threshold? Well, we use the geometry of screening of this curve. And essentially, the prevalence threshold really represents, it's the point of maximum curvature in that graph. And so you use essentially something known as differential geometry. You use calculus, if you will, taking the derivative of the curve to obtain its minimal value. And essentially, you get an equation that will always give you that point of maximum curvature, and therefore that point where the curve becomes more horizontal and less vertical. And not to bore you with equations, but essentially, you can calculate that prevalence threshold simply as 1 over the square root of the likelihood ratio plus 1. Again, 1 over the square root of that likelihood ratio plus 1. So the interesting thing, and this is what I alluded to before in the beginning of the presentation, is that when you're speaking in terms of likelihood ratios, and let's say that you have a patient that has multiple signs or symptoms or findings, the overall likelihood ratio for that sort of diagnostic scenario, if you will, is simply the multiplication of each individual one. So for example, if you have a symptom A that has a likelihood ratio of 2, a finding that has a likelihood ratio of 4, a result of some test that has a likelihood ratio of 3, well, for that patient, the system's likelihood ratio, if you will, is 24, 2 times 4 times 3. And you input that 24 on that equation 1 over the square root of 24 plus 1, and you get 16.9%. What that means is that the patient would need to be at a minimum of 16.9%, so that findings A, B, and C, 16.9% of risk of whatever condition you're testing, so that the symptoms A, B, and C ought to convince you or persuade you that in fact the patient does have the condition in question. And so the consequences, if you will, of the geometry of this curve is that if the prevalence or the pretest probability or the risk drops enough, most positive screening tests may in fact be false positives, right? False positive essentially means that you don't have a very reliable positive predictive value. And this makes an area of uncertainty and of doubt in clinical judgment. And from a public health point of view, if we test patients whose pretest probability falls below that threshold, what we're actually doing, we're likely to obtain a significant number of false positive tests. And as you can imagine, in a system such as ours, publicly, that increases costs, stress, and resource allocation, creating obviously delays for patients and a sort of a poor perceived experience for them. And this is sort of different tests showing you different curves. These are different levels of sensitivity and specificity. And so as you can tell, that area of sort of horizontal and vertical is not always as well defined, but that's why essentially we've created a decision algorithm, which essentially will tell you, you begin essentially by evaluating some risk of disease and some prevalence of disease in an individual, and we'll go a bit more into that after. You account for their signs and symptoms, and you take their likelihood ratio. You calculate using that equation that I showed you before, the positive predictive value. And then you ask the question, is this predictive value, does it reach essentially the prevalence threshold? If the answer is no, it means you need to continue. You need to continue gathering data because you haven't arrived at a level of sufficient persuasion to tell you, okay, I am convinced and I can move on to the next step, which is be diagnostic testing or treatment and therapy, depending on the condition in question. On the other hand, if you have reached the prevalence threshold, that's not sufficient because as we saw in the, as we saw in these curves, not all of that curvature is not as well defined in tests that don't perform very, very well. And so that sort of horizontal and vertical distinction at the junction is not always super sharp. And so the idea is that then you have to ask, is the overall likelihood ratio of your diagnostic system higher than some constant? If the answer is yes, and so therefore you've both reached the prevalence threshold and you have sufficient data, quality data, if you will, then you say you stop and you move on to the next step. On the other hand, if you do not, because the likelihood ratios of whatever signs and symptoms are very poor, then once again, you consider orthogonal or sequential testing, which is essentially you gather more data. So you need to meet those two criteria. It turns out, if you look at the math of sort of these Bayesian, the consequences of the Bayesian theory on the diagnostic system, you would need a combined likelihood ratio over 10 to be able to, the likelihood ratio of 10 is considered a strong evidence for ruling in disease. So you want to have a combined likelihood ratio over 10 and having reached that prevalence threshold, which is nothing more, like I said, than 1 over the square root of that likelihood ratio plus 1. So let's talk about a couple of clinical scenarios. Let's say that you see a 50-year-old man whose BMI is 32 and they're not known diabetic. He presents with the following. And let's say that the baseline prevalence in that age group in whatever society we're living in is 7%. Well, let's say then that he has polyuria, he has acanthosis nigricans, and he has a random glucose that's 8.9. You are getting essentially individual likelihood ratios. And these are values that are made up just for the sake of example. And let's say that you get an overall likelihood ratio of 38. That likelihood ratio, if you put it into that equation of 1 over the square root of kappa plus 1, you get 13.9%. In other words, it's telling you that a patient ought to be at 13.9% risk of diabetes so that the three signs and results that I've given you here ought to be sufficient to persuade you that the patient does in fact have the condition in question, and therefore you move on, in this case, to diagnostic testing, or in other cases to therapy, depending on the type 1, type 2 errors, and essentially the clinical urgency. But here, because the system's prevalence threshold is greater than the pretest probability of disease, you need to amass more information prior to performing diagnostic testing. And therefore, you can, in Bayesian terms, say this is the same thing to some degree as lacking confidence in your assessment thus far. And so when you essentially apply the equations for each of the signs, and then you put them all together, you see that the area under that curve really grows, and you see that demarcation, that sharpness between the horizontal and the vertical part a little bit better defined, and yet the red line is still beyond the blue line, and therefore you need to get more information so that you can then pass that red line and be on that sort of stable horizontal area where adding more on the x-axis doesn't really significantly change your y-axis. Let's say now in second scenario that you see a 32-year-old woman who's presenting with signs of, let's say, depression, and you want to screen them. Let's say that the baseline prevalence of depression at that in that age group is 13%, and she has symptoms of insomnia, blunted affect, and passive suicidality, let's say, and that gives you an overall systems likelihood ratio of like almost 80. Okay, and if you input that into your equation, then you get essentially a risk of, let's say, 10%. And what you see now here is that the patient's risk is already higher than the prevalence threshold of the symptoms in question, and therefore, in this case, you would perform either diagnostic testing if it applied here, or you will then use this tool as a triage for this patient to be referred more promptly than, let's say, somebody else. Now, I want you to imagine this in a public health context where everybody, those people with family history or no family history, with palpable masses or no palpable masses, get put into the same wait list for, let's say, a mammogram in this case, which is completely inappropriate because it doesn't account for these sort of individual risks. And in this case, as opposed to clinical scenario number one, is the same thing of having amassed sufficient confidence in your assessment to move forward. And again, you see the curves, and you see here that the blue line is a little bit beyond the red line. So I won't go so much into each individual theorem, of course, and we're coming to a close in the presentation, but one of the interesting theorems or properties, if you will, of the prevalence threshold is that at the prevalence threshold, regardless of the sensitivity and specificity, and I've put you different curves here, you reach the prevalence threshold when the sum of the pre-test and the post-test probability, each of which has a value between 0 and 1, therefore that their maximum sum could be 2, actually gets to 1. In other words, when the sum of your intuition prior to your testing and the screening results equal 1 or beyond, that's how you know you've reached the prevalence threshold. And that's essentially should be a benchmark for confidence in your clinical decision making. Another interesting theorem or consequence, if you will, in the book is this idea of a screening paradox. We know, for example, the Wilson-Jugner criteria, which are the WHO criteria from the 60s, which allow us essentially to establish the criteria for screening. We know that we should only screen patients that you can treat, and therefore that you can do something about. So let's say that you increase your screening, and therefore you're increasing treatment, but the treatment is actually going to decrease your prevalence. And the prevalence, when it's decreased, as you know, will decrease the positive predictive value. But if the positive predictive value decreases, then you're likely to find yourself perhaps with a false positive, and therefore having less point of screening or less, if you will, acute screening. In other words, by conducting the very role that the test is supposed to do, it loses its own efficacy over time in a closed system. And I'm going to show you just a quick graph of where you can see that. This is essentially an SIR graph. We do this in infection disease control, but if you look at the purple line, essentially you see that as the disease is growing in terms of prevalence, you're getting essentially an increase in your positive predictive value. And eventually you reach up an area where that predictive value kind of somewhat stabilizes before it starts to draw up again. And essentially that it stabilizes or it stops growing so quickly and dropping so quickly when you hit a probability that is beyond the prevalence threshold. So really beyond the prevalence threshold is what guarantees you that you will always get by screening people that are beyond that threshold, that you're getting more and more reliable results, and therefore you are decreasing your false positives. So last couple of slides, some of the remaining challenges and future directions. Of course, many challenges remain, but more importantly for me, standardizing a way to determine pretest probability is the holy grail, in my opinion, of clinical medicine today, and we have absolutely no idea how to go about it. The second thing is testing this theory in the clinical setting to establish the degree of benefit with regards to wait times, expenses, lived stress, and time to diagnosis, amongst others, would be key. And implementing this idea, of course, would require a paradigm shift in the way that we practice medicine in today's sort of litigious world. So determining ways to affect change in practicing clinicians will be required, and obviously that is going to be a lifelong process. Finally, in order to prevent this from, not prevent it, in other words, in order to ferment this sort of Bayesian reasoning, if you will, integrating these ideas into the medical school curricula would be key, obviously, in the long term. And, put a little slide about how we can use the prevalence threshold. While the prevalence threshold gives you a quantitative summary of a diagnostic system, it can also really serve as a heuristic to focus your diagnostic efforts on interventions that will sway the probability of disease one way or another beyond, let's say, this threshold. It can be used really as a reminder of our cognitive limitations and of the Bayesian nature of the real world, which is quite forgiving, right? I mean, you're getting partial information to obtain the right answer, particularly in systems that are well-defined. And really, it can aid in the planning of population-based interventions and triaging of patients according to risk profiles. So, take-home message, our primary role as clinicians is to establish the presence or absence of disease. We use clinical judgment and clinical decision-making to achieve this goal. Clinical judgment lacks a strict definition and is prone to biases and limitations that, in my opinion, can be addressed by sort of Bayesian theory and Bayesianism, which yields a framework to account for probabilities as degrees of belief and calculating the positive predictive value using this equation. We know that beyond the prevalence threshold, further information starts to yield diminishing returns, and therefore it can act as a benchmark for confidence in decision-making, or at least in the least to triage patients to move on into the next diagnostic steps. And obviously, as we know, this has applications both at the bedside and in public health. The interesting question to ponder, which is the philosophical implications of this. Is this really an approach that is novel, that really seeks to transform the definition and nature of clinical judgment? Or does it really merely reflect the reality that already exists in our brains, and thus this simply quantifies it? I think that's a question that remains to be answered. And yeah, I mean, we're currently in talks with the FMSQ for competition, essentially as a sort of an innovation, I guess, technique or idea that might get hopefully some funding. So that remains to be seen. But I want to thank you very much for your time, and I'm very happy to address any questions. I am here on my email address, or if you have Twitter or X, you feel free to reach out there as well. Thank you very much.
Thank you so much, Dr. Balayla, for that very insightful presentation and sharing your research with us today. We really appreciate your time and expertise. We can now open the floor to any questions or comments or that anyone has. Feel free to unmute yourself or raise your hand or type in the chat, and we'll go from there. I think Roland said something.
Yeah, Dr. Grad is asking, I think this has implications for medical education for learning about choosing wisely, but clinicians do not know pretest probabilities for many asymptomatic conditions. You're absolutely correct, Dr. Grad, and I think that this is really I was referring to, sort of the holy grail of clinical medicine today. It's not curing cancer. That's probably in my book a close second, but I think knowing essentially how to interpret tests and data so that we can accomplish that fundamental role is something that we have to find ways to do. And I agree with you completely. I think it's not, clinicians don't really know because it is not known even how to measure this. We have some ideas, and that's going to be the next steps in our research, but we're not quite there yet. Dr. Martin. Hi, Dr. Martin. How are you, sir? Are there any popular tests that we should consider abandoning? Well, pap tests are about to go soon, as you know. And the question about mammograms is in my book not answered yet, but I know there's a lot of controversy there. We'd have to look at the data specifically. But I think PAP's a good example of something that's going to go for the lack of.
No, absolutely. You're absolutely right.
Yeah. I think Dr. Schuster's raised his hand.
Yeah.
Yes, hello. Thank you so much for this very comprehensive presentation. So I teach statistical methods here in the department, and very pleased to see this integration of these quite advanced models into practice and conveying that to this audience. So thank you. I have one philosophical question, or maybe more semantic question, and one more specifically to some pragmatic issues related to these proposed screening tools and curves. You mentioned in one of these examples, the positive predictive value gives some sort of notion of confidence for the clinician, right? On how to act or not act on a certain test result. Now, the notion of confidence is usually reserved for the frequentist type of tool or domain, I would say, versus Bayesians try to avoid this term. It's almost like they're political, they want to
You're
use
absolutely right.
credibility. But can you tell a bit more about that struggle of using the right wording or that is plausible to the audience?
Yes. So maybe you can tell us what is the term in Bayesian theory for confidence intervals?
Well, credibility. We would rather
Credible
use
intervals.
credible
Yes.
intervals. Yeah.
I think confidence intervals in the statistical frequentist sense mean something very different than your degree of confidence as a semantic. I think it's a question that you're asking. It's very good. Look, you're right. I think the term is perhaps can cause confusion, but I think you understand what I mean when you're confident that you're sure, or you have a degree of certainty, if you will, as opposed to confidence. If you like a different word. But I think that's what I'm referring to more than the semantic sense, not in the statistical sense.
Yeah, and I would agree. This is one of the big challenges we have in communicating findings and make them intuitive. Because I would say per se, there's nothing wrong to refer to confidence, but it has been claimed for a long time by traditional frequentist statistics who have a very different lens to it. And my other brief question is because the post-test probability depends on the pre-test probability, right? If we have a very low prevalence of a condition, it will affect our positive predictive value, for instance.
Yeah.
Now, the examples you showed, the pre-test probability was relatively high, 7%, 10%.
Yeah, those were made up, by the way. They were not.
But in reality, they're very, very low sometimes, right? So when we talk about rare conditions, I think that is when I think clinicians have that issue. They see one case in a lifetime or twice. So are these tools you presented, how do they apply to these very odd and rare and uncertain scenarios?
So it depends on the clinical consequence. We test every single baby that's ever born for metabolic diseases that have an incidence of 1 in 50,000, 60,000. But we still do it for a 99% chance of having a false positive because clinical consequences are so dire and severe, and they manifest primarily asymptomatically, and they have essentially no confirmatory testing otherwise. In those cases, I think you're somewhat stuck. This idea, however, that you should check every box in a blood test to send patients for, just for the sake of dotting all the I's and crossing all the T's, that's the thing that I want us to shy away from. Because that doesn't really require any judgment at the end of the day, right? That requires simply just, a machine can do it. But that has actual consequences in terms of the management of our healthcare system, the cost, the perceived experience of the patient, and draining 6 gallons of blood from the tubes that you sent them for results that really don't add any clinical benefit to your conclusions whatsoever. And so I see your point, and I think it's well taken. There are certain limitations, and obviously with personalized medicine and genetic testing, the sensitivity and the specificity of some of those tests will hopefully overcome the restrictions or the limitations of the pretest probability. But that's medicine of the future. I think there's still things that we could do today to improve our system that comes from within, not so much from some administrative body. Thank you.
Thank you. Thank you.
Perfect. And then I think we have two questions in the chat, one from Albina.
Okay,
Yes.
go ahead. Sorry,
Yes, Albina, I think that you could
Oh,
go.
sorry, there's a question in the chat. I apologize.
I can read it. So she's asking, could an approach that estimates the PPV to identify the minimal required information be applied in family medicine research to find proxies or substitutions for costly or difficult to obtain measurements? For example, if certain questionnaire responses or simple lab tests yield a PPV similar to that of a more complex and expensive test? Example would be an MRI. Could this justify the use of these more accessible alternatives?
I would agree 100%. I think the issue remains finding those alternatives. Oftentimes, we tend to think of imaging and as almost not quite diagnostic, but almost a proxy for diagnosis, just because some tests, some pathologies, liver cancer, for example, get diagnosed not only screened with an MRI, but yeah, absolutely. If you had a tool that showed a significant yield in terms of its predictive value, that it was easy to administer, that didn't cost anything, and I would say absolutely, because at the end of the day, however you get, right, two people might be diabetic or two people might be menopausal and exhibit completely different symptomatologies. So it's not that there's a single recipe to get you to that threshold. We said depending on the patient's presentation, if you pass that threshold, then you should be sufficiently assured to not use the word confident that the patient in question does have the condition you're testing for. So the point is well taken, and I completely agree.
Thank you.
We have another question by Roland asking, should we use our admitted lack of knowledge around pretest probability in medical education? For example, if we don't know pretest probability, my position is that we should not be testing asymptomatic people given the false positive problem.
Yeah, I think that's an excellent point, Dr. Grattan. I believe that the ultimate decision that would be made has to do with the clinical consequence. Like missing a PKU in a baby could be catastrophic, let's say, versus, let's say, missing a yeast infection in somebody that may take care of itself eventually, or just because their friend had a yeast infection, they want to make sure that they don't. I mean, I agree with you. I haven't thought enough about whether abandoning screening altogether for people that are below that threshold should be a viable alternative. In my opinion, I think it should be more, given the reality of the conditions that exist, it would be just more an invitation to continue gathering information and not so much to abandon screening. Because yeah, sorry.
Yeah, thank you for your answer. This is really interesting stuff because we see a lot in family medicine, a lot of worried people who have no symptoms, but they're worried. And even on social media, you've got Kim Kardashian telling people they should have a total body.
I know.
Yeah,
I saw that.
I mean, this is just terrible stuff for healthcare because we don't know the pretest probabilities around scanning people with an MRI, right?
Correct.
And yet there's this kind of health anxiety out there that drives people to see doctors. And the easiest thing that we can do is just order the test to get them out of the office. But the reality is much more complex when the test comes back positive in some way, right?
Right. Or you have the incidentalomas, right? The scan for a spine issue, and all of a sudden there's something in the ovary or something. I get it. It's the realities of practicing medicine. I don't know that we have as a community the skills to tell a patient, sorry, I'm not testing you. I think you're right. I think that when there's a demand and this idea of patient being involved in their care, sometimes that causes us to do interventions that perhaps we wouldn't otherwise do. I don't have a solution, I don't think, at the moment, because I think this is the Bayesian reality of life, and we're always going to be, no matter what we do, short of continuing in that hunt for more information, there's the whole psychological aspect of diagnostics and the humanity of the individual in front of you that we have to take into account. So
yeah, that's interesting. I wonder if we shouldn't have some criteria though that says, look, given that you're a young person with no symptoms, the chance that we're going to find something meaningful is very low, let's say, and the chance that we'll find something that would send you down a rabbit hole is higher. So like, couldn't we develop some kind of criteria like Wilson and Jungner did for screening, and apply this to the care of just the worried well?
that would be fantastic. I agree with you completely. But the question is, how do you even get to that point?
Did you come across? I mean, you don't have thresholds, right, for pretest probability. Like, when does it? When does testing?
Yeah.
When does screening? In what circumstances is screening helpful? Like Wilson's criteria is that you have to have a problem for which there is a treatment.
Correct.
Right. That's why we don't screen for dementia right now, for example, because we don't have a good treatment.
Correct. Yeah. We it would be, I think, difficult to come up with a catch-all recipe for when to screen and when not to screen. I would have to think about it more, but certainly interesting to ponder because I think it would solve a lot of problems. You're right.
Yeah.
Go ahead, Laura.
Yes, thank you. So, Jacques, thank you very much for the presentation. It has been the second time, more or less, that I listened for it. That it's, I learn always something new. But I wanted to refer to one of your conclusions that these concepts should be taught in medical education. And our group is a family medicine education and research group. So what is, because it seems, as Tibor has said, it's a rather sophisticated philosophy, framework. How do you see medical students learning to do so? It should be reserved at the postgraduate residency program. What would be the level of epidemiological mathematical knowledge that a clinician would need to know?
If I am entirely honest, it is true that the mathematical tools to get that equation are fairly advanced with the differential geometry. That's certainly nothing that needs to be taught. But the idea that partial information equals nonetheless valid conclusions and knowing when to stop, I mean, that plays into our CanMed roles of being a manager, of being essentially of accounting for the sort of ethical principles of justice, where you have a limited resources and you have to do the best that you can with them so you can serve the public. You know, the equations that you do obtain after the fact, Bayes theorem is something high school students learn. 1 over a square root, I mean, we do that all the time in pediatrics and when we're calculating dosages and in obstetric and gynecology, when we're giving, for example, doses of methotrexate and we have to calculate body surface area, and we do this in dermatology also for concentrations of medications and so on. So the idea of using math in clinical medicine is not completely new. The idea, I think, would be to, more than using the numbers themselves, is just to internalize this idea that at some point we should stop the information collection, because further information is going to start to yield diminishing returns, may not fundamentally change our conclusion, and therefore can only add costs, delays, and perceived stress to a patient. I think, depending on how we frame it, I think it could be something that would be a viable tool to teach. But more than anything, I think this probably has better applications at the public health level, where you're trying to screen the baseline of the population, where you account for prevalence, not so much for pretest probability, and that's when you're really getting the bulk of your false positives.
Okay, thank you.
Thank you. I wanted to actually add something before we go to Dr. Grad's question, because one of the slides that I removed, you know, I don't know if Dr. Grad, if you do obstetrics or if you ever did obstetrics, but there are genetic tests that we offer women now during pregnancy, on top of their, you know, aneuploidy screening for Down syndrome and so on, which are known as the microdeletions. And the microdeletions essentially have a prevalence of 1 in like 60,000, 70,000, depending on which one. It turns out, if you do the mathematics, that it remains a screening test nonetheless. If you get a positive test on one of those microdeletion tests, you force, therefore, to send the patient for an amniocentesis, right, for a diagnostic testing. The amnio has higher chance of complication than the rate of true positive in that test in the first place. That is a test that should absolutely be completely absolved, short of there being a family history, which therefore shifts the pretest probability way beyond the threshold in this case. So
that's a great example. I mean, it's a balance really between harm and benefit, right? And the benefit is extremely small and the harm is greater than the benefit, if I understood you correctly.
That's exactly right. It's not a matter of benefit. It's just a matter of detecting whether it's a real signal or not. And the fact is that the finding out process, or the process to find out whether it's a real signal or not, actually carries higher risk than the chance of it being a real signal in the first place.
Yeah, I don't think we teach harm-benefit balance very well.
It's a problem.
The clinicians I talk to are overly optimistic about most of the tests that they order.
Right, but it's probably derived from these same principles. It's just that it's never been put in a framework that allows you to be so sort of calculating.
Okay.
Thank you.
Thank you so much.
Joshua, I think we need to close the event because it's already 1:30. So go ahead, Joshua. You're facilitating the group. Okay.
Thanks again, Dr. Balayla, for your time and your presentation. We really appreciate it. And yeah, thanks everyone for joining this FMER Advanced Research Seminar meeting.
Thank you.
Thank you very much. Thank you for having me. I appreciate it.
Thank you so much.